Hey everybody, it's Kevin and it's Donna, and welcome to another episode of the Med List. Donna, we've got a special one today. I've been talking to a lot of people about it prior to
Mhm.
us going live because it's just
Yeah.
such an important subject. And I'm also just really excited with your and Andy's connection and you bringing him onto the show. Just what a wonderful individual to delve into the details of something that's a really difficult subject. One thing that's not as difficult of a subject is I just had a dad that just had a birthday
I saw that.
just the other
You're
day.
very
So
good.
huge happy birthday to you, Dad. And I hope you're able to celebrate. Looking forward to you coming over and taking those grandkids from Savannah and I and getting to enjoy them here really soon. How about you, Donna? What you had going this week?
Oh, there's just lots of things going on. Lots of snow, unfortunately. I got my workout this morning through shoveling, and yeah, so it's just been starting off very busy already this week. But just lots of great things and good stuff with my students happening.
Oh, I'm so happy. All right, well, we'll get the show rocking and bring Andy on. You guys will love him. So just so the audience knows, several conversations that Don and I have just as friends, we're more like family, are really related around some of these pieces of family related healthcare, and different stages of life. And one of those important stages sometimes just it hits us so quickly, Donna, that we had no idea we had to deal with these things. We didn't know the benefits or the insurance covers that was available or the specialist that we could have in our corner.
Yeah,
I just think it's such an important topic.
yeah. Absolutely. And so, love to have introduce our wonderful guest today. It's Dr. Andy Arwari, and he is a hospice and palliative care physician and educator. I love all these things. Like, there's just so many things we can highlight that you do. Holistic, person-centered, interdisciplinary team care advocate. Just that in itself is just amazing. And author and medical director of Vitas Healthcare, Miami-Dade and Monroe counties. They're just so many great things. And, we were talking a little bit before, there's so much confusion about palliative care and hospice. And I was actually testing my students today and I said, hey, the podcast is on tonight. And I said, we're going to be doing palliative and hospice care. Tell me the difference. And they're all just like, yeah, I'm like, look it up. So we are going to
Wow.
get educated today because that's the standard answer. Nobody really knows or can explain it or explains it properly. So we have our expert with us. And I just want to say thank you so much, Andy, for being with us. And I love how we got connected on LinkedIn and kind of got connected between MedStrong, the book that I wrote, and your gracious commentary on that book. So thank you so much. And please let us know a little bit more about you and your background. And please tell us what's the difference between palliative and hospice.
Thank you so much, Don and Kevin, for having me, and thank you. I always think that these are great opportunities to advocate for hospice and palliative care, and more so for hospice because there's a lot of misunderstanding. So it's very important to get the message across about the fact that it is a benefit. I am an internist, internal medicine physician by background, worked in acute care setting for a very long time, um, did both inpatient work and palliative care, started a palliative care program, um, then transitioned in the last several years to work exclusively for hospice. And I work for Vitas, which is the largest and premier hospice provider in the United States. And I love what I do. I work with an amazing team of people, and we provide high quality end of life care. Um, I've been doing this for 20 years now. I consider myself very fortunate. As I always point out, it found me, I didn't find it. um, and there is a lot of confusion about a lot of things between palliative care and hospice. and what is one and what's the other, and are they the same? Are they different? Why do some patients have to receive one, and are they eligible for the other? I'm going to give you a little bit of a background because I think it's important to set the stage to then explain the differences and the similarities. And I would like to really start having people focus on why are they similar as opposed to why are they different and not the same. And then we can start talking about the differences. So I'm gonna take you on a little journey. So
Andy, before we go on the journey,
yes.
The one piece of the journey I wanted to hear is all the cardiologists I know, all the radiologists I know, the endocrinologists, there's a reason why, right? They chose that pathway, pharmacists, nurses, and specialties. And sometimes they're very personal, related to my individual family member went through these things. I knew a specialist in this space. Give us just a little bit of the journey, if you would, of why are you now doing what you're doing and having this particular specialization?
I think it all started really with personal experience that I had. My brother passed away when I was in medical school, and so I was exposed pretty early on in my medical, actually my first year of medical school, one of my brothers passed away, and I think that impacted me and shaped me. It exposed me early on to understanding death and grieving, and how difficult it is, and it sort of shaped the way I moved forward and what I wanted to do. I found that hospice and palliative care really at that point when I first started was what really got me closer to that holistic approach of care. And it really went beyond just treating physical symptoms, and it was more of getting to know the patient than just doing things for patients, right? Doing things to patients. It was for doing things for that patient.
Wow.
I was very fortunate, and I ran across a wonderful person, Miss Judy Chase, who was a nurse practitioner. And at the time, Judy was the person that was running the palliative medicine program, and she recruited me. I didn't know what it was, right? This was 20 years ago. And that meeting was, it changed my life forever. So I'm forever in debt to Judy. And I always say that hierarchy really doesn't have a place in medicine. You can learn things from anyone as long as they're a good teacher and they're willing to teach you. And so you just have to open up your mind and be willing to learn. And it was thanks to Judy that I started taking my first steps in palliative care and started learning about palliative care. And here I am still 20 years later.
Thank you.
I think, and as you'll see, I'm doing now a very specialized form of palliative care, which is hospice care.
Mm-hmm.
Well, thank you for taking us through that, Andy. And as you just mentioned at the end there, your two students up here and all the folks listening online are ready to listen to your journey.
So I wanted to give a little background, and I think it's going to be important to help you understand why we have palliative care and why we have hospice and the services, and then make some important distinctions. So the concept of helping and taking care of the poor, the destitute, the ill, what has been around since the 12th century. In Europe, hospices started springing up, and they were mostly relegated to religious orders. It wasn't until a British physician by the name of Cicely Saunders came about, and this was a very special person, very unique, who started off her healthcare journey as a nurse. She then went back to school. She was an Oxford trained social worker, and then went on to become a physician. And most importantly, she was an end of life researcher. That's the part that I think oftentimes gets left out, right? So Cicely Saunders is going to be a central figure to this discussion because she is the one that establishes St. Christopher's Hospice in London. And it may sound as this is just a hospice house. It is still a excellent. It's a center of end of life research, and a lot of hospice and palliative care luminaries were trained at St. Christopher's Hospice. One of these was Dr. Belfour Mount. Now, Dr. Mount is a Canadian. He was working at big, the Royal Victoria Hospital. He went to St. Christopher's Hospice and trained with Cicely Saunders, and then returned to Quebec. And he learned the vision of Cicely Saunders, which was holistic care, right? It wasn't just taking care of physical symptoms. It was the entirety of symptoms, including the psychosocial, the spiritual. So it started off with, this is the model of care for any symptoms, especially pain. So you can't just treat the physical aspect of pain. You also have to address the psychosocial and the spiritual. So it was the total pain concept. And you can translate that into any symptom, the totality of the pain. And in order to do that, you need an interdisciplinary team of professionals. Now, when Belfour Mount returns to Quebec, he thinks that he feels that he cannot call it hospice care, because in French, hospice had a negative connotation. So he decides to name this new philosophy of care Soins Palliatifs, which in French means palliative care. And that's how the term palliative care comes to be established in North America. Okay. There was another research fellow at St. Christopher's with Belfour Mount, Dr. Declan Walsh, who's going to start or establish the first inpatient palliative care unit at Cleveland Clinic. So this is how the palliative care services start getting their grounding or their footing in hospitals. And majority of the palliative care services are really in inpatient hospitals. And that's a great thing, right? But we'll talk a little bit more about the gap that we have now. So this is how we start having the term palliative care. Now let's go back to Cicely Saunders. Cicely Saunders in the late 60s came to the United States, actually in the early 60s, comes to the United States and starts advocating for this new philosophy of care, to such extent that you start having people start to establish local community hospices all around the country, especially on the East Coast. But they were really local models of care, and they weren't regulated. So you might have different types of services being provided to patients depending on where they were geographically. In 1965, we passed the Medicare-Medicaid law, right? And so what they started to find was that a lot of Medicare beneficiaries were receiving care in these local hospices. So you start having an interest in finding, the government starts finding an interest in trying to see how it can get hospice tied into the Medicare program. And in 1983, I'm making this short because I don't want to bore people, but in 1983, we passed the Hospice Medicare benefit. Hospice now becomes part of Medicare, and it is housed under Medicare Part A. So this is one of the things that I always advocate, and I think we still struggle with. Hospice is a benefit. It's an entitlement program. It's part of Medicare. I don't think that, and matter of fact, when I bring this up and I share this with patients and families, they're surprised. They're like, what do you mean? Yes, because we are funding our Medicare Part A, we are funding hospice. And we are the only country in the world that has a fully funded end-of-life service. We fund it throughout our work, right? Yep. So what happens when someone meets that criteria for hospice and they elect to enroll in hospice, that Medicare Part A becomes hospice. And this is why, you say, well, why is it that hospice is 100% covered? That's the reason why. because you are getting your Medicare Part A is becoming hospice now, and so this is where we start to have a little bit of the differentiation. So hospice became a federal funded program. Palliative care was mostly inpatient services, and palliative care was mostly provided to those patients who were inpatients and had a lot of symptoms. We had in 1995, there was the support study that showed how poorly we were providing care to patients who were nearing the end of life. There were gaps in advanced care planning. There were gaps in pain management. Patients were dying in the ICU. So this is how hospitals start to recognize that there's value to having palliative care services. Now, not every healthcare system in the United States, unfortunately, has a palliative care services. And unfortunately, we do not have a robust community-based palliative care. That's where there's a lot of work and advocacy to be done.
Mm-hmm.
And this is where we have this opportunity where we can really make it so that patients receive palliative care early on, and then when they meet their eligibility for their hospice, they can just transition to hospice. But they're not in opposition. They should be juxtaposed or a spectrum where one transitions into the other. And we still have a lot of gap. Now, there's another misconception about hospice, and that is that 6-month prognosis. So there's a lot of misunderstanding about that, and it's maybe misunderstood that you could only have hospice if somehow someone tells you only have 6 months left to live.
Mm-hmm.
That 6-month prognosis was not a medical or clinical decision. That was a financial decision by the Congressional Budget Office.
Mm-hmm.
And they haphazardly came on that number because at that time in 1983, they were the people that the hospice program was envisioned for were mostly cancer patients. So they fell on that 6-month prognosis. And what it really means is it reasonable to think that a patient might be at a point in their disease where it is reasonable to think that they have a prognosis of 6 months or less? And if the answer is yes,
Mm-hmm.
based on the evaluation, based on the parameters and the clinical judgment of the physicians who are evaluating the patient, then that patient is eligible for hospice. Again, it is a benefit. It's the patient that chooses hospice. We cannot make patients hospice.
Right.
That's so interesting, that 6 months piece there, Donna. And I know that has been a real confusion for lots
Mm-hmm.
of patients, and not realizing exactly what you said, Andy, is that it is a benefit. I mean, I compliment the VITAS team in their marketing and education, because looking things up, VITAS comes up very quickly when you're looking up any information, when you're looking at palliative care and hospice. And one thing that's pointed out on like a top things you need to know is that oftentimes families regret not getting hospice involved sooner in their care, right? Not getting them involved sooner in their care so that they could, one, be able to leverage all of the incredible physicians, clinical teams behind them and support, and two, to be able to bring that comfort level to their family member. Here's the two-part question I have for you. One, when it comes to that 6 months, right? When you're looking at that 6-month window that's determined by a primary care provider or by a specialist, whoever it may be, if you're getting discharged from a facility, that 6 months for the family to know that window is occurring or has been established. What can we do as caregivers, or even as patients, if we're noticing or we're feeling like an end of life component is starting to come to fruition for us, even prior to that hospital event that then is a discharge, and now there's a 2-week hospice period of time? What if we want to be able to grab onto that benefit, as you mentioned, a hospice benefit sooner? What steps need to be taken to be able to initiate it?
I would advocate that we all need to be educating patients and families about hospice. Mm-hmm. And we really should, again, have it be known that it is a benefit. I have a little joke, and I think that, if we had on our pay stub right, written down that they're collecting taxes to fund Medicare Part A / hospice, people would be more aware of it
Yeah.
sooner.
Mm-hmm.
They would say, "Oh,
Yeah.
I didn't realize that I'm funding this," and I think that happened. And I think that we should empower patients and families to ask early on about hospice. It doesn't mean that you're going to receive it, but it does no harm in knowing that it is a benefit and everything that's provided. And because it is a federal entitlement program, it is actually all written down for us. It's in black and white. And as a fact, there's what we know as the Code of Federal Regulations. Title 42, Part 418 talks about hospice. It has everything, everything, how it's going to be formed, who's going to be part of that hospice team, what patients can expect, what they're going to be receiving by hospice. And so when you mention this, or when this is brought up, and when we're educating our patients and our families, they're in disbelief. They're saying, "You mean you're going to give me all these things?" It's like, I'm not going to give you anything. That's what you're entitled to.
Right.
And we have to do it because that's what the Code of Federal Regulation actually states that we have to do.
So, Andy, I know that there's a lot of confusion as we've been talking about, and thank you for, kind of clearing the way with all of this. I think some of the things that people think is you have to have cancer in order to be able to be eligible, and we know that it can be any disease state that um, or towards the end of life. But what I'd like to know too is, and maybe this is some of my own confusion, is it true that you can enter palliative care really at any diagnosis just to kind of get an idea as to how to better live and the quality of life with a particular disease state? Or am I incorrect with thinking that?
Yes, and thank you. And I'm sorry because I should have clarified this. So the unifying um, philosophy for palliative care and hospice is that it is provided holistically and by an interdisciplinary care team. So it's a philosophy of care, whether we call it
Mhm.
palliative care or we call it hospice. Palliative care is for any patient that may have any disease or any distressing symptom, and it's supposed to be it is to be provided at any point in time. It does
Right.
not prevent patients from continuing to get what we call disease directed care. So patients can still see their specialist, they can still hope, and they can still continue to work towards their diseases. But the benefit, you say, well, why would you want palliative care? Because you are, and this is what I want to get across, is that you're going to get the support of an entire team.
Right.
And we're going to be addressing not only your physical symptoms, but your psychosocial and your spiritual. And at times, there are patients that really struggle with those aspects, not necessarily the
Right.
physical aspects, but they need psychosocial support, they need spiritual support. So that palliative medicine service, that's what they're going to help. It's going to complement the other services. And if anything, it's going to allow for a unified approach
Yeah.
to the care, as opposed to the kind of siloed approach that we have currently right now, where
Yes,
one patient may be
exactly.
going to see multiple doctors and they don't
Mhm.
necessarily always communicate the best way.
Yeah. Yeah. Um, so because we're on the med list, I'd love to also just talk about so what happens with medicines, right? And people get, a little bit confused about that as well. Like, oh, I have to go off of all my medicines, or and like you just mentioned, with palliative care, you can still hope, you can still um, get the care that you need. You can take medicines and be treated accordingly. Um, and then eventually, yes, there is this transition. What I want to talk about for a minute or two is I always think that deprescribing is part of optimizing. So no matter who you are, no matter what you're treating, we always want to be reviewing medications and thinking about, potentially deprescribing inappropriate, unnecessary medications. They might have worked at one point, maybe we don't need them anymore. And I think that that's the trajectory throughout. But I think people do think like, oh, if I go on these, I can't take any medicines. So could you just talk a little bit about medications themselves, the med list that people might see, and could you also just maybe share? I'm assuming that pharmacists are part of that healthcare team, but could you just enlighten us on that as well?
So I'm going to maybe start with the second part of the question about pharmacists. And remember, I mentioned that hospice is an entitlement program, and the structure of the core services are outlined in the Code of Federal Regulation. Again, this was developed in the 1980s. I think it's, personally, I'm going to say this, I think it's outdated. It needs to be revised. And pharmacists were not included as part of the core team. Big mistake. Opportunity for that to be fixed. I do think pharmacists absolutely should be included as core services. I have the great fortune of working with a great pharmacy team that are always available. I just only have to shoot an email or call someone. Again, I work for an amazing company that does its best and puts patients and families first. I don't know if smaller hospices may have access. They should, but that may not be the reality. So having reviewing, so let's start with the myth, right? And this is very common, that if you are in hospice, we're going to stop all your medicines. That's not true. That's not the case. There are some, how do I put this? Some maybe medicines that are actually going to be added, which makes it even more interesting to think about the fact that you now have more drug-drug interactions, potential side effects. So it is absolutely important to review a patient's medication list and wonder, well, if I'm adding something, will this affect what they're taking? So there's a lot to unpack here. There are 4 classes of medicines that are always going to be covered by hospice. And those are anything that has to do with pain, anything that has to do with constipation, anything that has to do with anxiety, and anything that has to do with nausea. Those 4 classes of medicine, whatever medicines we are doing to alleviate those symptoms, are always going to be the responsibility of the hospice entity. Now, the rest of the medicines, what is important is that we need to judiciously go over the medicines and think which one of these medicines are helping the patient with controlling their symptoms, and can we start eliminating medicines that are burdensome. And as you pointed out, right, that things change. I loved your book. It is so clear, and I wish everyone would read it because it has a lot of great insight. I highly recommend it. I think that irrespective of, not only hospice, but in general in healthcare, we should all be reading it. We change, right? And so you start to wonder, are the medicine, and so there's a lot of little details that I think I would point out. Think about it this way: if you go see your doctor, and I'll use an example. You're getting a statin because you have high cholesterol, and for years your doctor, your cardiologist, your neurologist, your primary care physician has been telling you, this is going to help to reduce your risk of having a stroke, a heart attack. It's important for you to take it. Oh, and by the way, we're going to do a lab to check the level. So you start associating how important this is because now you're getting your labs drawn. Mm-hmm. It's going to become very hard to let go of that, at least in the very beginning, especially if you haven't had the opportunity to have a discussion about why it's okay. So that's it. So starting to optimize, because I love that word, optimize medication as opposed to deprescribing, really has to do with being able to communicate the benefits versus the risk, why things have changed, and why you think that these medicines now are no longer going to help, or they may be burdensome. So one of the, you had asked me something a little bit before. I'm sorry if I'm jumping around.
No, you're great.
Important. So
Yeah.
you said, is hospice only for cancer patients? No, it's for any patient who is declining. And do we really, yes, there's a lot of confusion about diagnoses, right? So you have to have a specific diagnosis to meet hospice or get into hospice. No, you have to have a prognosis. So it's the prognosis that really drives the eligibility into hospice. And so there's what we call the domains of impairment. So we look at three basic things, right? We look at functionality, we look at nutrition, and we look at cognition. So I'll give you an example. If someone has, what do we do when someone has multiple diagnoses, but you don't really see one that might fit right into the box? It's important to look at these three things and see how that patient has been declining over time. You might have someone who now can no longer get out of bed. They're eating barely a bite of food, right? They're losing weight. They're emaciated. They're confused. Is it reasonable to think that patient is now at end of life? Yes. Is the diagnosis really that important? Not really. So we should not prevent patients from accessing their hospice benefit because we can't make them fit nicely into a diagnosis box.
For all the patients out there listening to what Andy just said, it's a really important thing to highlight. What Donna was asking about, is cancer the only diagnosis that can allow you to be able to attain the benefit that Andy has been highlighting? No, it is related to the prognosis. Is there 6 months or less to be able to have a survival benefit kick in? The other benefit I wanted to make sure that we highlighted real quick, Andy, was we talked about excluding what are called often excluding curative, correct? Curative treatments. And so you mentioned simvastatin or statins overall. I was hoping that in that exact same answer, when you're really saying, no, cancer is not the only diagnosis that will fit, is much related to prognosis, not to actual diagnosis. Same thing when it comes to those curative medications that go on board. Can you describe the benefit and what that means when you say they will be pulled off those medications, that it has to be an optimization conversation? Because I think that can be a real struggle for families to go, I've been taking these meds forever. I want to stay on these. What happens to my other benefits? Can I still go see my nutritionist, or can I see my primary care provider? Or what other things get taken from me?
Absolutely. And I just want to go a little bit deeper into the statin therapy, because that's the part that I think, I use statin as an example, right? Because we know that this has been studied, that if you were to stop the statin, what is the risk of you having a heart attack or a stroke? They found that in a 2-year period, the risk is actually there is no difference between you continuing the medicine or stopping it. So again, if we're talking about someone who has a limited prognosis, whether it be 6 months or a year, does it make sense to continue to take that statin, knowing that it's not reducing your risk? So I always think that the word is important. Are you preventing it or are you reducing it? It's reducing. It's risk reduction, right? So the question that the point we try to make to families, is it worth it for patients to continue on polypharmacy, on taking all these medicines, knowing that they really are not going to help? And so when you present it that way, people might start thinking, yeah, dad or mom is having a hard time swallowing. They're barely eating food. One of the points I always make is, well, would you rather give them this much of applesauce with 10 medicines crushed up, or would you rather that they enjoy a bite of whatever food that might give them pleasure? People start thinking, it's like, yeah, you know what, I'd rather them enjoy, eat that same quantity, but at least it's something that's food. And there are so many other examples. One of the other big ones that we have to struggle with are the anticoagulants, the DOACs. And so people are commonly placed on these medicines for atrial fibrillation to reduce the risk of stroke, right? Again, it's risk reduction. It's not prevention. And that's the point I always make to families is it's not 100%. You're hoping. And so when you look at the study that why do we use these medicines, it's because we know that we reduce the risk, which is measured in a year's time span, right? So you, depending on the different factors that we use to calculate, we know that it may cause a risk reduction by a certain percentage over a span of the year. If we're thinking that someone is declining and they have less than a year, does it really make sense to have them continue on these blood thinners, which potentially can cause bleeding, right? Because we know that as people become malnourished or they're already malnourished, they can have more bleeding tendencies, and now we're adding something that may cause more bleeding. Or and if they fall, right, which may happen because they're debilitated, that's going to be really devastating. So again, it's about education. It's about compassionately explaining these things and allowing people to process and come to terms with this. I will tell you, in my personal experience, I've had a lot of families who are grateful that I actually initiated, or we initiate those conversations, because I wish someone had brought this up, and they're eager to talk about it because they recognize that their loved one is taking a lot of medicines, right? So important to have those conversations. I want to go back to what you said. I know I'm jumping all around here. So primary care physicians are actually written into the Code of Federal Regulations. They are supposed to be part of that hospice team. We want that to continue. We want primary care physicians to remain. We never ever wanted to come across as there's an abandonment, because that made me seem like, okay, well, I'm pushing you to this service called hospice, and I'm no longer going to be able to see you. That's not true. We want primary care physicians to be part of the team. The Medicare, the Code of Federal Regulations actually states that the primary care physician is supposed to be part of that team. And I always point out that if the primary care physician stays engaged with the patient's care, the patient is actually getting two physicians now instead of one.
Right.
Because they get the primary care physician and they get the hospice physician, right? And all the team that comes with hospice.
Right.
So there's actually, and remember that hospice is Medicare Part A, right? Which is hospitalizations, rehabilitation services, therapy, home care, dialysis, hospice, all fall into Medicare Part A in general terms. And then Medicare Part B are physician services. So primary care physicians can still see their patients outside of any hospice diagnoses and continue to receive their, and this is not about billing, and really it's about care, right? But there's a mechanism where they can continue to see their patients, and they can continue to see them on their Medicare Part B. Right. So we want primary care physicians to know that it should not ever be a choice of, well, I'm afraid to send them because I might lose them. No, you're not. You're going to continue to be part of them as much as you want to be, and we want you to stay part and engage with them, because you are the one that knows them the best, and they trust you. And we need to build that trust around this end of life service that we're providing, because it's a delicate time and it's very emotional for patients and families.
Wow, that's so helpful. And Donna, the last question I had from the patient perspective that I'm trying to draw on is really, Andy addressed the meds, the medications that are reducing risk, and trying to have the conversation of decreasing overall pill burden, which I think we underestimate in society until you really delve deep into it. The other piece of losing the care providers that you feel connected to and are meaningful in your care, Andy talking about, we want you to keep those members on your team, and us to be able to be an enhancement, I think is really helpful. The last question that I get often and encountered as a hospital pharmacy director were things like this, Andy: respite care, or how am I going to take care of my loved one that needs more help? What is hospice going to offer me when it comes to day-to-day care? How much burden is put on the family? That piece, if you could go into that a little bit.
Absolutely. And thanks for this question, because I think this is a very important question. And again, I'm going to give you maybe a long-winded answer to this. Hospice is available to patients and families 24/7. And you have an interdisciplinary team that's going to be part of that care. However, there are many patients and many families who struggle because the reality is that they need a lot more support as far as doing the day-to-day things that a patient may need. Many caregivers have to work, and we know that a lot of caregivers may have to stop working. We know for a fact that a caregiver may be providing up to 60 hours a week of work just to take care. So it is a unrecognized labor of love that we have. Billions, right? So here's what I would say. We, as that part of that interdisciplinary team, can certainly work with the family to try to help them, oftentimes by providing agencies that might complement hospice. We might find community resources that might supplement. There might be programs outside of hospice that can help fill those gaps. But the reality is this, that there's a lot of need that's not met. So this is something that I do want to help. You read, and you still read, a lot of sensational news about hospice being this multi-billion-dollar industry, and that there's a lot of discussion about for-profit and non-for-profit, and those are things that I think that when they're taken out of context are things that may be barriers to patients accessing hospice because the way that they're being perceived. Again, hospice is part of Medicare Part A, right? If you look at the total spend of Medicare Part A, I'm not talking about the entire Medicare program, just Medicare Part A, hospice is only 6.5% of that Medicare Part A budget. That's not a lot, right? So the question really isn't, well, we're spending $23 billion in hospice. The real question is that enough? Should we be spending more? And who is getting the majority of that funding? Majority is acute hospitals. So Medicare beneficiaries to end up in acute care hospitals, that's where the government is spending most of the money. Can we somehow revisit that and say, you know what, we need to increase the spending for hospice so that we can somehow close that gap for families who need that extra support? Yeah. I personally think we can. I also think that there's an opportunity to also expand palliative care, not only in hospitals that may need full palliative care service, but for the community, so that, as we were talking before, those patients who don't quite meet the criteria for hospice, but need that support, that they need that holistic interdisciplinary care, are going to have access early on, and then they transition, right? And then it's a seamless transition into hospice, as opposed to, I went to the hospital, I kept going to the hospital, I wasn't getting better, and then all of a sudden someone says, well, it's time for hospice. And that's why it comes across as, yeah, they're giving up on me, or I'm dying now, when it really shouldn't be perceived that way. It should be like, oh my gosh, I have this benefit. So I think that, that discussion about for-profit or non-for-profit, I would ask people to reflect on the following. Again, 93.5% of the Medicare Part A fund goes to acute care hospitals. Do we really question which ones are for-profit or non-for-profit? No, we don't, right? If you need acute hospitalization, you're going to go to the hospital, right? You need care. And that's the point. Really, what I think the focus of hospice palliative care services should be on the clinical services and the patient care that we provide. How that's paid for, there are people that look at that, but it should never come across as a barrier, or we shouldn't really perpetuate that to the point that people are turned off and said, yeah, this sounds like, it's a money-making deal. It's not. It's not about money-making. It's about clinical care and providing high-quality patient and family-centered care to those patients that are end of life. And for those patients who are not, making sure they can have access to a high-quality palliative care team.
That's awesome.
Very, very helpful.
Yeah. So I think we're probably coming to the time now, but just thinking about the importance of optimizing our medications and also our healthcare and services that are available to us. Optimizing is my word this year for the new year. So I've been using it for lots of things. So optimize your healthcare. And I really do hope that people have really learned a bit more about palliative care and hospice. And what I always love to say too is that be educated, be enlightened, and be empowered, and don't be so scared about it. You know, I think I really appreciate, Andy, the positiveness that you brought to this and the importance that it is. We're all going to face mortality at some point, and you're right. Like, we should have this benefit in place, and we should use it. So I do hope that people feel more comfortable about talking about this and thinking about it, talking about wishes with their loved ones, and really embracing this information and bringing it forth to their providers too, so that they can kind of figure out where they fit in. Palliative, hospice, a little bit, seamless approach to optimizing their care.
Andy, I think some closing remarks I'd love from you, and then anything else you'd like to close us out on. But really are these: if we have folks that are listening from the clinician perspective or the patient perspective, and they want to get more information on what is hospice so I can fully comprehend this, some of the things that hospice is not, and the gaps, and maybe some resources on, I'm going to need some additional caregiver assistance, or I want to find out more about hospital respite care, where could they go, Andy? Any good resources for them to look at or to check out?
Absolutely. So I would say that the National Hospice and Palliative Care Organization has some really great resources that are online, and they're absolutely free. I would also advocate, and again, I'm going to say this, I think VITAS has a lot of great resources online for patients, just to, if they just want just general information, right? And then I think with just understanding a little bit more, or hopefully having curiosity, feeling empowered to reach out to their primary care physicians and ask them, can you please explain this to me? Can you share with me, if this is a good thing? Am I there? Are there palliative medicine community resources that I can be referred to, or my loved one can be referred to? VITAS does have a lot of resources that are made available to patients and families. I'm sure that other hospices also do, but there's a lot. And I know that that's confusing. I would really ask patients and families to have the courage to have those conversations, or start asking. And I also think that our healthcare community of professionals, and I mean everyone, I don't just mean primary care physicians, specialists, primary care, social workers, chaplains, should all feel empowered to also be able to have these conversations. And this is why it's holistic and it's interdisciplinary. It cannot just be a physician-led initiative. Pharmacists, right? Again, we need pharmacists to be integrated officially and as part of the core teams, both in palliative care and in hospice. But all of us are going to need to really start to advocate, to educate, and this is how we're going to move the ball forward. And I look forward to the future of all the great things that will come. And as you pointed out, Donna, we're mortal beings. It will come to us all. And so it's a choice. It's not really a choice of, I don't want this. It's a choice of, how is this going to happen? And I really do think that those patients that do receive palliative care early on are going to have an easier road, because they're going to be educated more about the disease process. They're going to understand more of their treatments. They're going to understand their prognosis. And those patients that do enroll in hospice are going to have, it's not about death. And this is the point that I always want to make and always highlight. It's not about that. It's about quality of life at end of life, if that makes sense. Yes. And for whatever time span you may have, that's what we want to focus on, providing the best quality of life for that patient and their loved ones and their family.
Mm-hmm. Yeah, it's beautiful. Well, thank you so much, Andy, for all the wisdom that you've given us today. Thanks everybody that was listening and tuning in. I think that I just really appreciate the one call I'm going to highlight before we end the show is Andy called it a benefit. And we know when Social Security starts, we know when Medicare starts for us, and we recognize those benefits for us and our families. Here's another benefit that I encourage you to look at, talk to your families about, and continue the conversation. Hopefully we'll be continuing this conversation. Talk to you guys all soon. Thanks for joining us.